Thank you for joining us. This event is jointly organized with Rocky Mountain, Harvard University Club, and University Corporation for Atmospheric Research Community Programs, also known as UCP. This also marks UCP's first community forum. We'd like to bring to you, through the forum, socially relevant topics that have connections with the earth sciences work we do here at UCP and at our university community. We'll be discussing current affairs topics that have direct impacts on our lives and on our work. I'm excited to be moderating this panel on COVID, climate, and public health tonight with Dr. Ari Bernstein and Dr. Michael Mina from Harvard. Thank you for joining us this evening, professors. The topic this evening is near and dear to me. Having grown up in Hong Kong and still have families there, I've seen firsthand how lives can be impacted by disease outbreaks. The city has seen its way through SARS and H5N1 and now carries a very different attitude towards the virus than the West. So I'd like to start by addressing the current state in the US. We're seeing some spikes right now in COVID numbers in some parts of the country. Michael, are the spikes in numbers concerning? Where have we come so far in the recent months?
Yeah, so the short answer is yes, it is extremely concerning. Where have we come? So it's now almost July, it's June 30th, and this virus was first detected back on December 8th. And so it's really, not too long ago, by the end of last November, still the world had not heard about this virus. And now in half a year, it's become, of course, something that has changed our societies in profound ways. And I think where we've come in the United States anyway is unfortunately not as far as we would like to have come, at least in the positive direction. Things seem to be getting under control back in late April and May. The expected turns that we were hoping to see were happening, and that was because of major social distancing efforts that took place primarily in New England and in the Southeast and in the Northeast and in the Northwest, and where some of the early infections really took off, like New York City, for example, and Boston. We both had very major epidemics here. And so I think we saw an initial flurry of activity to get testing up and running as soon as possible, and social distancing did seem to help. Of course, now what we're seeing across the country is a different picture. Whereas we saw big peaks in some of these places that were hit very early, we're now seeing cases sort of flood into the rest of the country that weren't hit as early. And I think as a result, we saw a lot of people not really have a need to have their guard up in the same way that New York City, Boston, Seattle, and some other places had to in order to control the early waves. And now we're seeing this sort of first wave of infections really roll across the country in a what's seeming to be a pretty devastating way. Cases are now higher in many states than they ever got in many of the places back in April. And there doesn't seem to be a good solution to the problem at the moment, at least not that the country is really focused on. There are ways to mitigate transmission, but it seems to be running unabated in much of the geographies of the U.S. at the moment. So I was hoping that by this point we would have a much more optimistic view of what the summer was looking like. But at the moment, I just don't feel that way, I guess.
Yeah, thank you for that. So when we think about the numbers, actually, when we look at the prevalence data, a lot of that is not quite adjusted for the testing level. So how much of it is because of wider availability of tests versus, an actual spike? Can you elaborate a little bit more on that?
Yeah, that's been a question lately, and it was certainly a question early on. A lot of the, for example, the early epidemiological modeling efforts were really focused on the first part of the waves of these infections, and many of those estimates were not entirely accurate because it was so confounded by increases in testing, which at the moment, or at the time back in March and April, were truly increasing exponentially, so it's hard to disentangle them. But since then, we've seen a steady rise in cases. We've seen a steady rise in testing that has been largely going up linearly over the last few months, couple of months. But we were seeing rapid reductions in cases for a long period of time over the last couple of months. And now we're seeing, not surprisingly, as places started to open up again, in a pretty expected fashion, we have seen cases begin to increase. And so while I think it's a perfectly good question to be asking, very little of the new increases in cases that we're seeing are really likely to be driven by the increase in testing, and it does seem to be really driven by behavioral changes as people have sort of emerged from their homes and gone back to work and gone back to picnic and everything else. We've seen cases just transmit, and they're doing so very, very rapidly.
And a quick follow-up, and then I'll turn it over to Ari. So with that, then, when I think about the numbers, how much then also is it because of improvements in treatment? How far have we come in terms of treatment? Because when I think one of the audience members asked, although we are seeing more cases, we are actually seeing that the death rate hasn't really spiked as fast as the number of cases. So how have treatment evolved in the last few months?
Yeah, so I would first caution interpretation of that. Deaths tend to lag by at least 2 to 3 weeks, if not more, depending on, they were lagging around 2 to 3 weeks before, and but people were usually getting diagnosed later in their course of infection. So it could be that deaths are potentially lagging as much as a month behind recent cases because people are getting diagnosed much more quickly now. So we have only really seen cases tick up in the last 2 weeks. So we still don't have a good understanding of whether or not deaths will. There is no doubt in my mind that deaths will increase. But part of this is also, I think that on the one hand, we have begun in the acute care setting to learn how to better treat patients than where we were months ago. But more so, I would say that we have the behavioral changes that have probably led to an increase in the numbers of cases seems to be being driven in large part by people who are younger. What we are doing is we are focusing more now today than we were, say, in March and April, on figuring out how to really do our due diligence and keep places like nursing homes and senior living centers a little bit safer and prevent outbreaks from entering in and sort of catching fire there. So in that sense, I do hope that we will see reduced mortality overall as we are able to better prevent infections from entering into places full of very highly vulnerable individuals. And so in that sense, I would say it's probably not as much about actually becoming more familiar with how to treat people and keep them alive as it is probably the demographic of people who are really getting infected is probably being driven by behavioral changes of sort of getting back out in the house. And I think across the country, I think there's still probably even places that are really expanding in terms of people getting back to work. There is still a lot more caution, particularly amongst people in age categories that would be considered highly vulnerable, people above 65 and certainly above 75. The rates of mortality increase greatly after 75 years old and after 65. And so I do think people are making, in those age categories, and their families, hopefully, are making appropriate efforts to keep them safe.
Thank you for that context, Michael. Now, Ari, I have many different sets of questions I want to ask you, but I want to have you start with perhaps helping us set the stage and connect the dots of how is COVID tied with climate. Can you talk a little bit about those interlinkages, either upstream or downstream?
Sure, Janette, and thank you for the chance to be here, and thanks JK and John, and we got plenty to talk about. So, you know, the question of climate change and COVID comes up a lot. And I think that the short answer is that there's no evidence whatsoever that climate change itself had anything to do with this particular virus getting into people at this particular time. But there are certainly things that wrap these two things together. And it goes, you know, all the way from what we know about emerging infections like this virus. There have been probably about 75 or so viruses that have moved from animals into people over the last 70 years or so, one or two, maybe more a year. We know that those viruses are not just sort of randomly popping up on the surface. They get into people through people coming into contact with animals. While we don't know exactly how this virus got into a person, we're pretty sure it came from a bat because coronaviruses like MERS or SARS, these are other coronaviruses that many people may have heard of, live in bats that live in China. And there are other viruses like Ebola that also live in bats, and there's very good evidence that deforestation in particular in West Africa has led to the bats being in closer contact with humans. And we've seen this pattern time and again. We've seen it with a virus called Nipah virus in Malaysia. And in China, it's interesting, deforestation has actually been very well controlled in China. In fact, the forests are coming back. But the question is whether that, in fact, the new forests are suitable habitat for bats is an open question. The other difference is how people behave. Bats are routinely consumed in certain parts of the world and not in others. We know that deforestation is a major risk for these emerging infections. Deforestation is a major driver of climate change. We have evidence, including research from the Chan School and Rachel Nethery and Francesca Amici, and now some dozen other studies around the world, showing that air pollution, breathing bad air for many, many years increases the risk of dying from this disease. That air pollution is overwhelmingly coming from burning fossil fuels. Those are the same things that are contributing 80% of our carbon pollution problem. And so we can achieve real benefits, not just to COVID outcomes, but to pretty much any respiratory infection. This air pollution is bad for all kinds of things, particularly respiratory infections. And we can do something about climate change if we stop burning fossil fuels. And then there's very basic stuff. You know, in the United States, although we'd like to think that everyone has access to potable water, we now have reports that particularly in tribal communities in the United States, including in the West, where many of you are, there are tribal communities which don't have access to clean running water. It's a big problem if you need to wash your hands, right? So the cornerstone of prevention here for transmission is hand washing. This is an even bigger problem around the world. And of course, climate change is substantially affecting people's access to water. And perhaps the most important thing that I think ties climate change and this pandemic together is they really both exploit inequality. You know, we've seen, you know, inequality pop up as a major threat to everyone's welfare in all kinds of ways, but there's really been no moment in recent memory that has made it so abundantly clear that we really ignore we really stand to imperil everybody by ignoring the inequalities in our society. The people who are first affected by this virus were the poor, those who could not afford to protect themselves. We see death rates among African Americans much higher than among whites. And the same can be said for climate change. And so if we want to build resiliency to pandemics like COVID, or we want to build resiliency to climate change, we really do have to pay attention to the fundamental inequalities in the United States, which have been sort of laid bare right in front of us with this pandemic.
Thanks for setting the stage, Ari. So with the inequality that you talked about, how I think a lot of it is system-based, and if we really take a step back, like what could we have done to prevent this? Can you talk a little bit more about those synergies at a system level?
Well, I think, Janette, there are important things we can do right now about these issues, and we can focus on air pollution first and foremost. So we know that people of color and the poor breathe more air pollution in the United States. That's because air pollution is sourced from the cars and trucks and things that go, as well as fossil fuel power plants in the United States. And people are exposed, are people who are poor, people of color. And so the most important thing we can do is to get ourselves off of polluting fuels and produce energy through non-polluting fuels. That has huge benefits for everybody, but that disproportionately benefits the people who've been affected most historically. You know, there are continuing systemic problems with race in this country. And they've been, you know, raised because of the, you know, ongoing mess that is police brutality against people of color in the United States. And you know, people are really talking about how to reform these systems so that people are treated equally. And so, you know, I think that there are a variety of ways in which actions can be taken right now to address health inequalities. We certainly in medical practice have huge disparities in care that remain. And I'm mindful that, you know, in my practice in pediatrics, whether we're talking about COVID or anything else, working in my hospital is not a random sample of children who show up in the hospital. It is overwhelmingly children who are raised in poverty. We still have 1 in 5 children in this country who are raised in poverty in the richest country in the world. And so we need to figure out the things that can be done right now to improve their welfare. That starts with things like access to childcare. You know, and, you know, we could talk a lot about that if people are interested, but these are fundamental issues to equality in the country. And they are part of the solution of resiliency for children and everyone when it comes to pandemics or climate.
So when we talk about those interrelationships between climate and COVID, sounds like there are some synergy in terms of like if you're able to do reforestation, that helps both to mitigate climate change as well as potentially the source of like COVID, which is the emergence of animal-borne diseases. At the same time though, when we think about the idea of sustainability and cities and mass transit, that there seems to be, on the other hand, there could be this fundamental tension between public health or energy efficient types of solutions with pandemic solutions. The reason I say that is like now people are like nervous about riding public transportation, right? They're ready to just like drive their own cars. And some even talk about the idea of the death of cities, that we should just move back to countryside. With that in mind though, then like, is it really the death of cities? Like what is the future of cities and also public transit? I know you're working on some of a multi-state climate and transportation initiative. So maybe can you talk a little bit more about, can we invest in solutions that simultaneously support the pandemic and climate change?
Yeah, I think there's a lot of concern about the things you raised, Janette. I mean, public transit at a time of pandemic is not necessarily a wise thing to do, to crowd people into, you know, trains and so forth. There have been a lot of concerns about, you know, cities being amplifiers, but it strikes me that the solution to the problem is not to depopulate cities and to end public transit, because those actions, of course, carry huge problems for health that would be long-term. So, you know, I think when it comes to resiliency, and we see this in the climate space, is that many of the actions that would be important to address climate change are going to promote resiliency to a whole host of other problems. So we can look at any number of issues. So obesity, you know, prior to coronavirus, obesity was arguably the, you know, and will remain, hope when this virus eventually leaves us, you know, be probably one of the biggest, if not the biggest threat to American health. It is not really well treated in the American medical system. We don't have a great track record of curing obesity. Once people are obese, it is very difficult to lose weight, as anyone knows. And so, we also know that obesity is a major risk factor for, dying from coronavirus. So obesity promotes diabetes, it promotes high blood pressure, promotes heart disease, the diseases that are increasing risks of death from the virus. It's a big health problem. So what does it take to deal with obesity? Well, obesity, when I started medical school, was sort of a rare problem. I mean, the rates of obesity have gone up in the past few decades at a staggering rate, such that something like a third of Americans are obese. And we were the first country in the history of the world where obesity was associated with poverty. Usually, if you were overweight, it was a sign of affluence. So again, we have this amplification of a health effect among the poor. So how do you deal with obesity? Well, you look at the diets people are eating, whether people have access to exercise. These are two fundamental things. And we know that, for instance, eating highly processed foods, particularly red meats, are bad for health. They're certainly not going to make people lose weight, particularly refined sugars. And that, plant-based diets that involve more fruits and vegetables, particularly unprocessed, are good for all kinds of things. They promote, healthier body weights and are also, of course, less carbon polluting. The other side of it is exercise. So people are sitting in cars for longer periods of time. Boston last year received the dubious distinction of having the worst traffic in the United States. And people I know commute into Boston from Maine. So we need to recognize that our transportation systems are also a major determinant of obesity. There are large cross-sectional studies in Europe looking at transportation mode and obesity and showing that, if we're able to walk a bit more and bike or even just take public transit as opposed to sit in cars, we may in fact have healthier body weights. So those actions, again, rely less on burning fossil fuels. And so there's benefits to air pollution, there's benefits to obesity, and of course, there's benefits to the climate. And so, as I said, many of these actions, and there are others, have sort of very broad-based effects on improving people's health and build resilience to everything from climate to things like coronavirus.
Yeah, so there are a lot more broad-based actions we can do to promote resiliency. So it doesn't have to be either or, is what you're saying. You brought up chronic diseases, and actually, Michael, I think you have talked about the plight of public health, that like the more we do, right, like the more we do in terms of interventions, the less people see it, even if we're successful. So I guess in two ways, like first, like what can we do to better raise awareness or combat that perception?
Yeah, I think it takes a lot of public messaging from our policymakers, for one, and from people who actually have platforms that other people listen to. I think it is a plight of public health. It's very similar to vaccines, and anytime public health works, the whole goal is for us not to see things. So with vaccines, vaccines against measles have gotten to a point where measles is largely out of the public eye, at least in most countries. And so it's led a lot of people to not recognize the ongoing benefit that we get to diminishing measles through vaccination. The same thing here is, I mean, it really is across the board. As long as a program in public health is working, the whole idea is to give people an opportunity to not have to worry about that particular issue. And that is a goal. And so how to deal with it was something that needs to be ever present in some ways, like this virus. It is a difficult thing. And I recall back in March, a senator called me up and asked, what they can do from their platform. And my single comment was, by the time we get to May, people are going, if we're successful at shutting down and sort of social distancing, people are going to hopefully not understand why they had to social distance. because they won't know many people who actually got infected. And by and large, that's what happened. Of course, it was on the news a lot, but most people, not everyone, of course, but most people don't know people personally who have passed away from this virus. Of course, many people do, unfortunately. But the point is that those measures were sufficiently successful that people didn't have firsthand experience with it because they were all social distancing and in their homes. And so that is a very difficult thing to balance. How to continue allowing the public to recognize the fruits of their labor when the whole goal of their labor is for them to not see those fruits even have to be apparent. And it's just a continual problem and difficulty that I think the only real way to help solve that particular problem is with very good public messaging. There should be media campaigns that are designed not just surrounding what's going wrong with things, but celebrating people's ability to do things that are working. It's not, of course, how our society tends to function. We don't usually celebrate things on a daily basis that are just working well. But if we do that, I think that's one thing. Of course, now I would say that our country as a whole, it's not working well, but many countries have had the opportunity now to be celebrating diminished coronavirus in their populations. And so I think that's one small thing that could be done.
And the other part to what Ari was talking about was the fact that chronic diseases is still also a big issue. And when I think about COVID, when we look at numbers, I think it's the same in Colorado as in Massachusetts, that outpatient visits have largely decreased. That my understanding is at Mass General that the number might have halved. And there's the worry that people might be missing critical routine checkup appointments for like heart diseases and stroke types of conditions. Or maybe in terms of pediatrics, in Colorado, we are seeing less well child visits. So for a state like Colorado, where we already have one of the lowest rates of child vaccination, that is definitely something that's concerning, right? Like it's creating, it's the idea of we might be getting a hidden epidemic that's left unaddressed. So what can we do are we doing enough to address those areas? Like how can we better address those sort of blind spots?
Is that for me? Yeah, I think, Janette, you're absolutely right. I mean, the across the board healthcare systems are losing volume. And there's a real question as to is that because people didn't need care? Is that because people are having heart attacks at home and, surviving them and, or not? And I think there's going to be a lot more work to look into that. And there's obviously, as you point out, a lot of concern about childhood vaccination rates falling. And there have been measures to really try and get into communities and have mobile vaccine clinics, but, they're not going to replace, standard care. I think that to me, one of the critical things about this moment in terms of the healthcare piece is 2019 was a record year for healthcare closures in the United States. There were more hospitals that closed in 2019 than any year in recent decades, and 2020 was forecast to be even faster. And that was before coronavirus hit. And so we're really losing access to care particularly for people in rural areas. And so this is a big deal when it comes to, how we deal with the virus. If a mainstay of the virus, if controlling the virus is access to testing, we can hopefully set that up. But as we lose facilities, it becomes harder to do. And again, the virus is exploiting the weaknesses in our society, and it's really showing how our healthcare system, we in Boston, I think, narrowly escaped what happened in New York, which was, severe overcrowding of facilities. But no one wants to be in a place of care where, you're really needing care of a particular level and there are no beds for you to have it, no facilities. So again, it comes back to, and I think Michael raised this point as well, which is prevention here is really critical, right? We can't really operate in a space which is dealing with a pandemic of the scale, and I think that would be, and I think the good news there is we do know how to prevent these things.
Yeah. I want to bring it back a little bit more close to home, because I know our audience have a lot of questions around, some of the questions are around testing, and also like just day-to-day on a practical level in terms of the science. So with that in mind then, Michael, in terms of contact surfaces, can you update us on like what's the latest science around that right now? For example, if I go to the grocery store and to get groceries or maybe mail, how much obsessive washing should we really be doing at this point?
Yeah, in general, I think it's become fairly, the virus can technically transmit on surfaces, but going and worrying about your mail, it's probably not going to be the major driver of transmission. I would not say that it's not going to be a possible driver of transmission to some people, but certainly not much has changed in this regard, to be honest, in terms of sort of surfaces over the last couple of months. I think it's still a good idea if you're going and picking up groceries at the store and you're touching things that probably a lot of people might have touched. I think it's still a good idea to try to wash these things off and clean them off. But in general, what we do know is that for the most part, the virus will largely not live for very long periods of time on surfaces. There were some early reports, for example, on some of the cruise ships that the virus was being detected 2 or 3 weeks after an infected person was there. But that's actually, it was not live virus that was being detected. It turns out the test that we use can essentially detect the genome of the virus and the RNA from the virus, even when the virus is no longer alive. The vast majority of this virus, if it's on a surface, will die in hours, and then usually in a day. It would be extraordinarily rare, I think, to pick it up. If you are sitting in a classroom or something, or at a table, and somebody who just had who has a fulminant infection was sitting at that table right before you, and you sit down, that is a way that I think, in the same seat, that's a way that potentially you could get infected if you're touching the surface of the table and smearing it on your face or something. But in general, I think the major modes of transmission are still droplet transmission, somebody coughing, somebody speaking out loud, somebody sneezing. These are the types of things that cause droplets to fly out of somebody's mouth or nose and potentially float into the air a bit and get other people infected. So I think that those are some of the major things. You could still, I would suggest people who are in elevators or opening doorknobs, I would say it's still very, there is a chance that the virus can live on metal surfaces for a decent amount of time. So I would suggest anytime you're touching things like that, just carry hand sanitizer around with you and use it liberally.
So in terms of transmission, one of the audience questions we got was around how long do people stay infectious? And so particularly specifically, they asked for people, 3 types of folks. So for people who were tested positive, how long do they stay infectious? For people who are pre-symptomatic, how long does it take for them to, from exposure to the time that they show up as having symptoms, and then how long do they stay infectious? And then thirdly, for people who are completely asymptomatic, how do we know how long is that window?
Yeah, so the course of infection, from the moment somebody gets infected, it's usually somewhere between 3 and 5 days or so before somebody becomes even able to be detected on a test. So if you've been exposed to the virus and you go to the physician and get a test that day, there's a very high likelihood, in fact, there's almost 100% likelihood that you will not come back positive. 2 days later, 3 days later, you start becoming positive. And that's usually around the same time that, not surprisingly, that people become symptomatic as well. It's usually within 3, 4, or 5 or so days. Some people can start transmitting the virus a little bit of time before they become symptomatic. So if somebody becomes symptomatic at 5 days, for example, there's a possibility that they can transmit the virus a day or so before they actually recognize their own symptoms. And usually actually the most transmissible period though is usually actually most likely an acute period of time. It's probably not weeks, but it's probably on the order of days. And that's because the virus grows very fast. Once you're infected and once you become positive on a test, it's really sort of the virus is growing exponentially through the cells of your respiratory tract. Your immune system will generally start to beat it back, and it will essentially, you'll get to a point where you're no longer transmissible, usually probably within 5 or 6 days after that. People can then stay positive, however, for a very long period of time. And so just so that I'm clear, some people will stay transmissible for more than 5 or 6 days. So a minority of people will probably continue transmitting for another week after that. But the vast majority of transmission events will happen probably within that first 10-day window from exposure all the way to 10 days later. But a lot of people will then remain positive on the types of tests that we use for weeks, potentially months. And in general, our most up-to-date understanding of this period of time when people are remaining positive, but are not showing symptoms, and you can actually take the virus out of them, and you're not able to culture it. It's not live virus. It's just viral RNA that's kind of floating and staying in somebody's system for long periods of time, trapped in these little vesicles in the cells. And so that's a problem, because it means that a lot of people who are getting detected as positive have actually already gone past and through their infectious stage. So by the time we're then testing them as positive, our chances of capturing them and actually getting them to quarantine and not transmit to other people have already passed for a lot of people. And then we still put them into quarantine for 14 days, despite the fact that they're already on the other end of their transmissibility. So it's a real problem that one of the solutions to that is going to be cheaper, more frequent tests. And I think over the next few months, we're going to start seeing the introduction of tests that are going to be able to be used at home, for example, very rapidly, and they'll hopefully be cheap enough so that people can actually use them on a regular basis, and hopefully catch themselves before they are actually transmitting. But at the moment, unfortunately, a lot of the people that we are finding to be positive who are asymptomatic are probably actually beyond their transmissible period.
So for the ones that are available at home, how do we judge the quality in terms of the DIY tests so that we know what to buy? And then also, are those generally the antibody serological tests?
So there are no at-home tests at the moment that give you an answer about the virus. There are becoming at-home tests that you can use. You can swab yourself, and then you send it off to a laboratory. So that will incur a few days delay actually before you get results, and that has its own problems. But I think the best way, so we'll break that question down. You have viral testing and antibody testing. Virus testing is what most of the conversation has been about, what most people who have gotten tested for. And that, I think that the best thing to do there is to go to the CDC website and look at what the quality of these different tests are, what are being recommended. Look for if there's warnings about certain tests, probably try not to use those, although there are some warnings about certain tests which actually work very well, like the Abbott test, there were warnings about, but it's actually a very good test. Unfortunately, those came out. But in any case, so it is a little bit difficult to understand exactly which tests to do. There's a few that are at home now. LabCorp has a test that you can order at home. Everlywell has a test that you can order at home, and you can get those, and they're literally shipped to your home, and then you mail them back. Then there's antibody tests, which unfortunately the early antibody tests that showed up during this pandemic were terrible. They just didn't work well. There were these little plastic things and people got very excited about them because they were giving people results in 10 minutes. But it turns out they just so frequently don't work. I have a few boxes of them in my house here that I was given to trial, and they just all failed. And so what my recommendation for antibody testing is to recognize that antibodies, tell you if you have been exposed, but not if you're infectious. So they're very important, though, to know sort of what your status is. If you thought that you might have been exposed 3 weeks ago, an antibody test can give you that information. And there are very high quality ones now, but they're almost all still sort of clinical tests. So you have to usually get your blood drawn at a physician or at a Quest or LabCorp type of facility and send off the blood. We're going to start seeing an increase in availability of high quality antibody tests that will be through sort of dried blood spots. Somebody gets a kit, they prick their finger, they drop a few drops of blood onto filter paper, and they mail it back to a laboratory. So those are becoming more widely available, and they can be very good both for surveillance and serological surveillance to know sort of how many people have gotten infected in an area, for people to know what their status is, have they been infected. I'll caveat that with saying we don't fully know how to interpret it, but we do believe that most people who have been infected recently will probably have some level of protection. But we're trying to work out exactly how to interpret the data and how to give people advice on what level of protection they probably have.
So is the level of antibodies, if I do test positive, tied to my level of immunity?
Well, certain antibodies, yes, and certain antibodies, no. So it depends on which test you're using. It could be, it could offer that kind of information, but at the moment, very, very few. I don't believe that any antibody tests at the moment that are commercially available are giving people an actual value. It's just giving yes or no. And that's going to hopefully change in the future because those values they do have information stored in them. If somebody has a very high titer, we hope that over the next few months, we'll be able to figure out how to better interpret these values and the quantitative numbers so that we can start giving those to people so that, and a clinician could talk to their patients about what it means. At the moment, though, we just don't have the research isn't yet at a place where we could confidently say much about a specific test value.
With summer approaching, I see a few questions about travel. So one was asking, would you fly right now given the current state of the virus? And what would be the kind of protocol that you would take if you do choose to fly? And also, if or when, like what kind of signs do we actually look for, if not right now, to know that it's actually now safe again to fly? Can you speak a little bit about that, Michael?
Yeah, I'm happy to. I don't know, Ari, if you have anything you want to add before I answer it, or
This one's definitely up your alley, Michael. I would say though, I put in the answers. There have been many sort of practical questions, and Michael's center at the school, along with some the Healthy Buildings group, have put together a bunch of resources, and I put links to them that provide guidance around questions around air filtration, personal protection equipment, a whole suite of practical stuff. And I put in 2 links in the Q&A that people may find helpful. And before I get back to you, there's another thing I would say, which is this question, which was a really good one about these tests and how people get tested and what's safe. And you know, I think we need to answer those questions because we're at where we're at, but it really, you know, in this particular as a pediatrician, we shouldn't expect, you know, people in the United States to have to sort out what a good test is on their own, right? You don't come to a doctor and say, is this blood test for diabetes a good test or not? That's not the patient's responsibility, right? So we have a systemic problem here, which is we haven't been able to get a system in place that provides a good test so that people don't have to ask that question. I mean, when was the last time you had to go to a doctor and ask the doctor, you know, which brand of the test should I buy? And so we've got a lot of work to do there. I think it's pretty apparent.
Yeah, that's actually a good point. Maybe I'll put up a table or a blog post on the Harvard CCDD website to talk about that and give people recommendations. But so the question that you asked was about flying, and My first recommendation is if you don't need to fly, probably don't fly. It's airports, maybe even more than the flights themselves. Airports funnel people through channels to get them to terminals, and then there's lines and crowds, and so I think as much as people can still stay out of these types of public spaces, I think it's just beneficial. Some people will have to fly though, and so if you are flying, I would say first and foremost, try not to touch things. It's really hard not to touch things, but try not to. And make sure that you have a bottle of alcohol, the gel stuff to put on your hands, frequently. Wear a mask. Wearing a mask will go a very long way in this epidemic to prevent transmission. It is a droplet transmitted virus, and so the more people who wear masks, the better. The more recent research is showing that if you wear a mask and you are with somebody who is even infected and they are wearing a mask, the chances of transmission are very low. So just this simple act, there's very minimal adverse consequence, if any, to wearing a mask, and so I think it's just very, very important, and it can serve to keep people safe. I would say that if you are in a vulnerable age category, really, I just don't recommend being out in an environment like that unless it's completely necessary. If you are not in a vulnerable age category and you're going to visit somebody who is, I would highly recommend trying to self-isolate and quarantine for 5 days or so after you fly. And then try to get yourself tested at 4 or 5 days. So again, the idea of you don't want to go and get tested if you're trying, let's say you're going and visiting your parent in a nursing home who you have to fly to see. You don't want to get a test the day you get off the flight, or even the next day, or even the day after that, and assume that that test is meaningful for the next few days. This virus does take a while from exposure to the time you become positive. So you probably want to wait 4 days at least before getting that test and using that as a metric to understand if you can go into a place like a nursing home. So that's something I would highly recommend, is just trying to seek out a testing facility if you do have to fly somewhere and you are planning to see somebody who might be in a particularly vulnerable age group. Again, above 65 and up, the mortality rate that is associated with this virus just increases exponentially. So anything you can do to prevent transmission of the virus, unknowingly perhaps, because there are so many asymptomatic people, to somebody who could be in a particularly vulnerable state, it's well worth the effort.
I see a few questions about masks. What's a way to encourage people to wear masks given the culture?
I think we need PR campaigns. I think we need to socialize masks to be useful, especially places like college campuses and inside companies and businesses. People are going to be very quick to take off masks. They're not comfortable a lot of times, and I think we have to redesign masks. We have to design masks that are going to be very comfortable for people to wear, and we just need to continue socializing their use. We need to have marketing campaigns that continue to remind people that they are useful. And I think that's, and we need to truly discourage people from going and partying without them. They're not going to be, they won't be, I'm sure that there are going to be plenty of locations when people don't wear their masks, and that's just going to be a fact. But as much as we can socialize behavior to wear them, especially in places where transmission may be abundant, I think that it's important. There was just a super spreading event at a bar, I believe in Michigan this week, where something on the order of 85 people got infected. That's a huge number of people to get infected because somebody wasn't wearing a mask, most likely. And, so it's just very, very important.
Related to summer, we have a lot of scientists also in the room, but just can you comment on atmospheric conditions in terms of temperature, humidity, or maybe UV rays? Do those have any impact on the viability of the virus?
We don't really know what leads to the seasonality of coronaviruses. And so it's unclear, is it absolute humidity? Is it just heat? The short answer is we don't know. We know that the virus is sufficiently seasonal, or I should say, we know that the closest neighbors to this virus is very seasonal. So it usually comes down in the summer and then blasts up again in the fall. And so we're very nervous about that happening. We're seeing that it's clearly, and it never was, I don't think any of us necessarily thought that it was going to stop in the summer if people's behavior didn't change. And you could think of it as momentum of the virus. There are so many susceptible people in our community that even if the summer months, for whatever reason, could cut transmissibility down, it wouldn't necessarily stop the transmission. And that's essentially what we're seeing now. My concern is that this is still a seasonal virus, despite the fact that we're seeing it continue to increase in the summer right now. I worry that it is going to turn out to be a seasonal virus, and the increases we're seeing now are going to continue. And then if we bring these into the fall, we may see fairly catastrophic effects in terms of transmission. But at this point, we don't know for sure, because this is the first time we're actually going through the seasons with this virus.
Well, maybe that is pointing to an opportunity for more research and partnerships, potentially in those areas.
Sure.
Yeah. Ari, I know you've put out great resources around the idea of heat waves and stress. Can you talk a little bit about who's most at risk, and how is the risk higher now that we have COVID?
Well, I think to the point about the temperature in particular, and the SARS coronavirus that Michael was referring to, I think the jury is very much out. We certainly have seen plenty of spread in places like Singapore or the South, where it's been plenty warm. And at the same time, we know that heat is a big challenge, and particularly for people who are most at risk from coronavirus, right? So if you look at heat and who gets sick when it gets hot out in the summer, it's people who are older, people who work in outdoor occupations. And so the mainstay of dealing with heat in a public health response, in a sort of where the rubber hits the road kind of way, is trying to get people into cooling centers, particularly older people. And that strategy doesn't work so well at baseline, meaning before we had a pandemic, and now you can imagine it could be harder now because people are probably understandably going to be reluctant to go to a place where a bunch of people are getting together. And even with social distancing and mask wearing. And so a lot of cities around the country have been trying to figure out how to do this. That applies for hurricanes. In Florida, I was on a webinar with the mayor of Miami. Their whole response to hurricanes is to get people into shelters to protect them from the storm. People are at risk. It doesn't work so well if you have coronavirus. And so I think there are, there are new challenges on these strategies that have been the cornerstone of preparedness. I think, Janette, this conversation, it's clear that folks are very interested in how to protect themselves, and, what can we do with testing? What can we do with protective equipment? What can we do with ventilation? How do we protect ourselves from GI transmission? And these are all important questions to ask, but the question that we're not asking is, why are we here in the first place? And do we have to be? I mean, how many people on this call would rather have a world without this pathogen causing this disaster? I would like to think that everyone would want that. And the reality is, we know how these viruses emerge, and we know the actions that we're taking that essentially force them to emerge. They're deforestation, they're the trade in wild animals, and they're the intensive farming of livestock, meaning crowding lots of animals together in particular. And, this is a probably at least $10 trillion hit to the global economy in one event. We spend, the United States and globally, maybe somewhere on the order of $10 to $20 billion a year dealing, that's being generous, in dealing with these things that we know cause these pathogens to spill over, which is, I've alluded to, You know, these viruses, particularly viruses, move from animals to people on a regular basis. A couple a year are discovered. And so it really begs the question, maybe now's the time to start thinking about dealing with the root cause of this problem rather than trying to clean up the mess afterward, because, you know, we don't have answers to a lot of these questions, is the truth. And we're not going to have them necessarily for the next one that comes. You know, we need to bear in mind, just in coronaviruses, in the last, 20 years, we've had 3. Now, one of them has been much worse, which is this one, don't get me wrong. But there's, HIV. HIV is a virus that came into people through exposure to primates. And the list, as I said, there are dozens of these viruses. And I think that's the question we need to ask more of, which is, what can we do so that we're not in a situation like this again?
What you just said sounded like, it's not a matter of if, it's a matter of when we're going to get the next pandemic. So, I mean, over time, I've seen curriculum getting developed around like Ebola, like our pandemic response. There have been a lot of good materials that have been developed. And perhaps, lessons learned along the way. What do you wish that we have learned and applied then that we didn't? Like, Michael, do you have anything to add to what Ari had said just now?
Well, I think what I've taken away from this, and which isn't a surprise, it's been known for decades now, is that public health generally is underfunded. We don't have, it's a different bend on it, but we don't have surveillance systems in place for pathogens. We are unable, even in the wealthiest country in the world, to know where the virus is in our country without just looking at sick people and people who are getting hospitalized. And so we really need to create networks of monitoring systems that don't stop at boundaries. What I would like to see happen, and what I've been calling for in recent publications and media and things, is to create an immunology, or a sort of a global observatory, to create a weather system for pathogens that the world can rely on. The data for which becomes public, it allows us to know when pathogens are emerging. It allows us to start to understand how to best prevent pathogens from emerging. If we can, it's very similar to where we were decades ago before we had a weather system in place. In general, the idea of being able to predict the weather was seen as crazy. And certainly the idea of being able to turn on your computer and put in a country in the world and know what the temperature is there just wasn't a thing not too long ago. And now I think we all recognize just how valuable that is to our lives, and companies and the global economy in many ways relies on understanding these global patterns. And I think we should really think about trying to create something very similar for the world for pathogens, because I mean, as Ari just mentioned, this is a $10 trillion hit on the global economy in one fell swoop. The amount of money it would take to really set up these systems is a small fraction of that. And if people would just, the problem is that in peacetime, people don't put money into preventative things like a network of monitoring pathogens. And I think we're seeing the downfall of that. At the very least, we should have the ability within our cities and hospitals to be able to, or not necessarily within our hospitals. I think we actually need to decouple testing from clinical care. Right now, testing in our country is completely associated with clinical medicine, insurance reimbursements, and things like that. We need to start making testing a routine part of just public health monitoring. And there might be really interesting ways to do that that we're seeing emerge as a result of this pandemic, like having robots go into sewers and test for this virus. That's a very passive way to be able to do testing for a pathogen in a community. And I think we should really start thinking more creatively about how to put money into these sort of surveillance networks.
In closing, then, what would you like to share with the audience in terms of what's one thing that you are most hopeful for going forward? I'll turn this first to Ari and then Michael.
I think the greatest hope we have is that we're going to learn from this experience and do things that we need to do to prevent it from happening again. It's not clear, it's clear that vaccines are in development. It's not clear how good they're going to be. We can hope that they work really well and they're really safe. But at some point, we have a tendency to, as a species, to forget things like this. But my hope is that we'll be able to use this experience to really make the world and the country much better off in a variety of ways. And I think the pain of the moment really pushes to think towards the solutions that really provide the broadest based benefits to health, as I was talking about previously. I think it would be a grave mistake to simply say, let's pump a lot of money into making sure we have a national strategic ventilator supply, as has been floated, so that if this happens again, we'll have enough ventilators. I mean, yes, we need enough ventilators, but that would be, a bandage of large proportions on this. There are much better ways to spend money in terms of keeping people well off here. And the other thing is I think, I'm hopeful that this event makes clear that we can do everything we want to protect our own health. We can eat the right foods, we can get enough sleep, we can exercise, we can even socially distance, but viruses don't frankly care. If there are parts of our country, our communities, or the world where the virus can gain a foothold, it's going to thrive there, and that's a problem for us. We see this in our own country. In Boston, we have enormous disparities in infectious rates, and it's not only not okay that there are those disparities, but it's a problem for everybody. And so, my hope is that when we see this so clearly, it'll really motivate us to think differently about how we handle inequality, because it turns out that that's a problem for everybody.
Michael?
I think that one thing that I hope will be gained from this is, or that I'm hopeful for, I suppose, is for this to just demonstrate that I guess on the one hand, how fragile humans are. This one virus is pushing us, to completely change our social structure, at least temporarily. And in many ways, it's a humbling experience, if not a terrible one for many people. And so I always hope that these types of events will bring people back to earth, and we have just tremendous resources in the world. They end up getting sucked up by a very few number of people or companies, and it's I don't know. I guess I look at events like these as opportunities for commonality to come about and try to push resource equity, because that is, very much in what the types of things that Ari's been discussing. If there's one thing that is coming to light as a result of this virus, is although the virus doesn't really doesn't itself pay attention to who it's infecting, certainly we're seeing that the people most affected are there are discrepancies and disparities, and there are socioeconomic and racial and all these things, and there's just very clear lines of who's getting most affected by this beyond just age. And I hope that this can drive some level of equity, or at least continue to raise awareness surrounding the need for it. That it's not just that it really does bleed into things like how to deal with the pandemic. If there are some groups on Earth where this virus is transmitting widely, that causes everyone else to remain unsafe, and so it just continues to send a message that we need to recognize that we're kind of all in this together. I think the other piece is that I am hopeful, I suppose, that this virus is going to push us to just recognize that preventative healthcare in general, public health and preventative medicine, are just much more affordable, especially in this country. We don't have a good approach to actually practicing preventative healthcare, and I think what we're seeing now is sort of a population level of not practicing preventative public health, and all of it, I mean, the economic costs are just devastating. And I hope that, you know, people will will understand that there were ways to prevent this from getting out of control, that there still are ways to prevent it from continuing to get out of control. And it's usually not fun, but it's usually much better than the consequences of having it continue to ravage society. And so hopefully we will learn that preventative medicine can actually work. Yeah,
we all hope that everyone understands the importance of prevention, and also the idea that we are all in this together. Absolutely. Well, once again, I want to thank you, both of you, for participating and sharing your wisdom with this group. I really, really appreciate it. It's, you know, a later evening for you both. So thank you so much for participating. And until then, until next time, thank you so much, everyone. Good night.